Once again, very warm welcome to Mindray's webinar with another unique topic, fetal arrhythmia by Dr. Maniram Krishna. With the mission statement of better healthcare for all, Mindray wants to spread the flame of knowledge to nook and corner of India. Let's start this session with a technology update from an industry expert. Let's welcome Ms. Jayashree Ramesh to give us a brief introduction about a brand new model, DC60X Insight. Over to you, Jayashree.
Thank you, sir. A warm welcome to everybody, and I am Jayashree R from Mindray India Ultrasound team. I'm very happy and very proud to introduce our product DC60 Expert X Insight, which is fabulous with 2D color, Doppler, and a whole body ultrasound imaging system. It has a lot of wonderful, exciting, unique features, and we shall go through that. So first, we have the concept of X Insight. So what is X Insight? The first thing, demand insight. So we have designed this product in such a way that we understand the customer's daily work and their requirements on the ultrasound machine and evolving technology. So we realize the customer's demand by continuous development of our new technologies. And third, the infinite scalability. So with full of vitality, the goal of Insight is actually to improve with increased scalability. With all these things, the clinicians will be benefited with reduced scanning time and high image quality without making too much tuning and parameters and faster 3D, 4D acquisition. So it all comes with our Thunder Speed Imaging X engine, which is a combination of graphical processing unit and the central processing unit together. So this architecture improves the image processing speed 3 to 4 times faster, especially for the 3D, 4D imaging where the fetal movements are too high, and also to optimize the image quality with continuity. So apart from this, we also support solid state drive and the hard disk drive. So memory is not at all a problem and boot up time is very quick. So then comes our touch and bingo, the cutting edge transducer technology, which we have in this. So we have our 3D technology with triple matching layer, total cut design, and thermal dissipation for better penetration, better resolution, and better 3D, 4D performance. And we also have our combo wave technology on the linear probes, like we use our composite material for better spatial and contrast resolution and better image uniformity. So then comes our smart plane CNS, which is Mindray's exclusive technology for fetal CNS examination. So this is a fully automatic deduction of standard CNS scanning planes, and also the automatic measurement of 6 anatomical parameters takes place in this. So we have a 3D image. I just do one touch, I get the transcerebellar plane, the transthalamic plane, the transventricular plane, and the mid-sagittal plane. So I do one more touch, I get all the measurements, BPD, OFD, HC, TCD, cisterna magna, and the lateral ventricle width. So this is a feature developed by Dr. Philip Gianti for Mindray, and we have tried innumerable cases, and this is 99% accurate. And all cranial measurements in a single touch with reduced scanning and measuring time is the benefit this feature gives us. Then comes our smart FLC, smart follicle count. So this is an automatic detection of the number and to calculate the volume of follicles from a 3D volume image. So it gives the benefit of accurate assessment of the size of follicles, and also the sizes of the follicles can be sorted with color code. So dominant one comes with red color on the first, and reporting is also very easy so that the doctors could use it for later follow-ups. So next we have our iLife, which is a revolutionary photorealistic image rendering algorithm for the fetus. So in this, we have actually integrated a virtual and movable light source, and also the light source adjustment is possible. So we can see a pretty baby with nice lips and nose. So this is our iLife technology. So with this technology, actually the benefit is that the clinical and diagnostic confidence increases to a great extent, and also when the mother sees the fetus, her rapport also becomes very great. So this is our excellent, wonderful image gallery of our DC60 Expert X Insight. So we have one more variant called DC60 Echo in this, which has single crystal transducer technology. So the single crystal transducer's main efficiency is that it improves the acoustic transmission efficiency, and Mindray gives best penetration in class and best resolution in class with the combination of single crystal and 3T technology together. So we have the adult cardiac probe. We also have the pediatric cardiac probe. We have the neonatal cardiac probe, and we also have the transesophageal transducer. Last but not the least, it also supports our advanced speckle tracking technology in 2D, which is the tissue tracking quantitative analysis. And this is our super image gallery. I hope everybody can see it. X Insight. It is an all-rounder partner whom you can trust and great to go with. Thank you all. I'm happy and thankful to everybody for watching this. Thank you so much. Over to you, Arumugam, sir.
Thanks, Jayashree. It's a wonderful presentation. Thanks for updating us with the new product. Let me introduce our speaker. Dear all, Mindray is very proud to introduce young, dynamic, knowledgeable pediatric cardiologist, Dr. Maniram Krishna. He is a clinical assistant professor and clinical lead pediatric electrophysiologist at Department of Pediatric Cardiology in Amrita Institute of Medical Sciences, Cochin, Kerala. Also, he is the chief consultant at Tiny Hearts Pediatric and Fetal Cardiac Clinic at RK Hospital, Tanjavur, Tamil Nadu. He has got a lot of academic achievements in his life. Few are he is Dr. Balagopal Raju, gold medalist in DNB Pediatrics. He has done his fellowship in pediatric cardiology from the Children's Hospital at Westmead, NSW, Australia. He has written articles over 20 publications and more than 5 textbook chapters. His areas of interest are pediatric cardiomyopathies and inherited arrhythmias. Mindray, once again, very happy to introduce Dr. Maniram Krishna. Welcome, sir. All yours. Over to you, sir. You can start share your screen, sir.
Yes. Can you all see my screen now?
Yes, sir, very much, sir. You can start slides. Yeah.
Good evening, everyone.
Yes.
I hope in these difficult times, everybody is very safe. And during the next 40 minutes or so, I'm going to discuss the very basics of fetal arrhythmia. Now, this session, I'm going to stick to the basics. I'm not going to go into complex arrhythmia detection and management. And as you all know, heart is essentially a pump. The heart has 2 atria, which are collecting chambers, and their job is just to collect the blood from the veins and send it down to the ventricles. The ventricles are the pumping chambers, and their job is to pump the blood out into the great vessels. Now, this has to be very coordinated. When the atria contract, the ventricles should be relaxed and to receive the blood. And once the ventricles are filled with blood, they should pump the blood out. And this sequence is maintained by the conduction system of the heart. The conduction system is similar to an electric current passing. So it originates, as we all know, from the sinus node and spreads to both the atria. And as the electrical activity spreads, the atria contract. There is a delay before it goes down to the ventricle. The delay is predominantly at the level of the atrioventricular node. And once the electrical signal passes down to the ventricles contract, pushing the blood out. So sinus rhythm is essentially an atrial contraction first, followed by a ventricular contraction. Every atrial contraction is followed by a ventricular contraction, and the atrioventricular ratio is typically 1:1. Now, what are the fetal heart rates? They are very different from what we see in pediatrics or in the adult population. They're probably similar to what we see in neonates. The normal heart rate is between 110 to 180 per minute. Bradyarrhythmias are defined as heart rates less than 110 per minute, and tachyarrhythmias as heart rate more than 180 per minute. Now, these can be transient or sustained. And how do you define sustained tachyarrhythmias? A typical ultrasound evaluation for anomalies usually lasts 30 minutes. And if the arrhythmia is present for more than 50%, then you call it a sustained arrhythmia. So what exactly are these fetal arrhythmias? We know from data all over the world that up to 2% of pregnancies can be complicated by an arrhythmia. But thankfully, a large majority, close to 85%, are paroxysmal arrhythmias. They're usually very transient and they do not have significant effect on the fetus. These paroxysmal arrhythmias include premature atrial complexes and very rarely premature ventricular complexes. Bradyarrhythmias account for close to 5% of all the arrhythmias, and these include sinus bradycardia and complete heart block. Tachyarrhythmias usually constitute close to 15% of all the arrhythmias. They can be sinus tachycardia, they can be supraventricular tachycardia, they can be atrial flutter, or a host of other arrhythmias. I'm putting all the others together in one group because the differentiation is more an intellectual discussion rather than affecting patient management. And supraventricular tachycardia and atrial flutter constitute more than 90% of significant tachyarrhythmias in the fetus. I'll be explaining each one of them in detail in the following slides. What are the tools we have to evaluate a fetal arrhythmia? If a child presents to me with palpitation, I need to just stick ECG leads on the child and I'll know immediately what the rhythm is. Now, in the ideal world, we like to take an ECG of the fetus. It is possible. All you need to do is stick the ECGs in the maternal abdomen, ECG leads, identify the lie of the fetus from an ultrasound examination, and then put it through a complex mathematical program to get this ECG. But unfortunately, this is still a research tool and is not widely available. What is available in Western countries is what is called a magnetocardiograph, which can provide you data about the ventricular activity. But unfortunately, this is an extremely expensive equipment. And to the best of my knowledge, is not available outside United States and Europe. So what is really practical is to do an ultrasound. And there are many ways in which we can understand the rhythm by ultrasound. The most widely used is the 2D ultrasound. You can also use M mode, wherein you cut the heart through one atrium and one ventricle and try to understand the relationship between atrial contraction and ventricular contraction. You can also do pulse wave Doppler, and the commonest used Doppler is the inflow-outflow Doppler, which gives you information about the ventricular inflow, which is a reflection of the atrial activity, and the ventricular outflow, which is a reflection of the ventricular activity. You also use SVC aorta or pulmonary artery pulmonary vein Dopplers to further refine the identification of the arrhythmia mechanism. I'm not going to talk in great detail about these in this current talk. In 2D, it's all about pattern recognition. So for anyone who does fetal ultrasound, looking at this, they'll know that the heart rate is very slow and that they're dealing with a bradyarrhythmia. And that here, the heart rate is very fast and that they're dealing with a tachyarrhythmia. Slightly more experienced operators can also pick up transient abnormalities based on just eyeballing with 2 dimension. But if you want to know the fetal heart rate accurately, the easiest method is to get an umbilical artery Doppler. Now, the umbilical artery Doppler only provides you the number of ventricular contractions. It does not tell you anything at all about the atrial activity, but it does give you a ballpark figure about what the heart rate is, and it helps you to define bradyarrhythmias and tachyarrhythmias. What is more useful is an M mode. So in the M mode, you should align it in such a way that it cuts across one atrium and one ventricle. It need not be the same atrium and ventricle, like it need not be the left atrium and the left ventricle or the right atrium and right ventricle. In this figure that you see, it is cutting through the left atrium and the right ventricle. Now, both the atria contract in unison and both the ventricles contract in unison. So you don't have to cut across the same sided atrium and ventricle. You just need to cut across one atrium and one ventricle. In the 2D picture above, the atrium is closer to the probe, and so the first activity which you see on this M mode is the atrial activity, whereas the ventricle is further away and the lower activity is that of the ventricle. So you can see that with each atrial contraction is followed by a contraction of the ventricle. So one atrial contraction, one ventricular contraction, one atrial contraction and one ventricular contraction. And when you measure the rate, they are pretty much the same. So this is normal rhythm or 1:1 AV conduction. You can also use an inflow-outflow Doppler. This can be either the left side, as it is in this case, or the right side. So this is the baseline for the pulse wave Doppler, and the activity above the baseline is that of the atrium, whereas the activity below the baseline is that of the ventricle. The atrial activity typically has two waves, what we call an E wave and an A wave. It is important to remember that the start of the A wave is the start of atrial contraction, whereas the start of the ventricular activity is the start of the ventricular contraction. So you can also measure the distance between the start of the A wave and the start of the V wave, and that will give you an idea about AV interval. I'm going to go into it in more detail on the talk during the Bradyarrhythmia session. You can also get a pulse wave Doppler of an artery and vein. So in this case, we've got a pulse wave of the pulmonary artery and pulmonary vein. And you can see that there is a V wave, which is a much larger velocity and represents ventricular activity and is seen from the pulmonary artery. You can also see a reversal wave, which is from the pulmonary vein and represents the atrial activity. But it is important to remember that what you see on 2D ultrasound is the mechanical event. That is the contraction of the atrium or the ventricle. And you do not see the electrical events. They're usually in sync with each other, but there are exceptional circumstances in which they may not be in sync with each other. And it is important for us to remember this, especially in long-lasting tachyarrhythmias. Sometimes the atria might be very big and may not contract effectively at all, and you may hence not be able to pick up atrial activity on Doppler or M mode. So what you see on ultrasound is only the mechanical event and not the electrical event. Are everyone able to follow me up to this point?
They can send a message in the chat. You can see it in this chat section, sir.
Okay. So with that, we'll move on to the individual arrhythmias.
You want to do polling now, or we can do it again? All those 5 questions.
So before we go to the individual arrhythmias, I've got a set of questions here, just to assess how you manage the various arrhythmias. And I'll be happy for all of you guys to take a go at it and then see if you want to revise your answers at the end of the talk.
Can I launch polling now?
Yes.
Now all the participants can see the questions in their screen and they can answer it. The people who joined through Zoom, they can see the questions. Other platform, they may not be able to see it. If it is YouTube or Facebook, they may not be able to see it. There are 5 questions. You can answer all those 5 questions. Sir, hope you are able to see the trending,
Yes,
how they are answering.
yes, I can see them. Yeah.
Okay, sir. For the benefit of people who join through YouTube and Facebook, I will read out those questions so that they can, they can also come to know what are the questions are. First question is, what are the commonest arrhythmias in the fetal period? First answer is premature atrial complexes. Second answer is tachyarrhythmias. Third answer is bradyarrhythmias. You can, if you want, you can answer it in YouTube also. The second question is, an antenatal mother presents to you at 28 weeks of gestational age. You notice that the fetus has heart block. The fetal ventricular rate is 60 per minute. Which of these therapies will you consider? The options are dexamethasone, IVIG, salbutamol, induction of labor. Third question is, a mother presents with decreased fetal movements at 37 weeks of gestation. There is fetal tachycardia with a heart rate of 270. You deduce that it is SVT. The treatment of choice will be what? The options are delivery, direct fetal therapy with digoxin, maternal digoxin, maternal sotalol. The fourth question is, your drug of choice for fetal tachycardia without hydrops is? The answers, digoxin, direct fetal therapy, sotalol, filakinide. Fifth question is, a mother presents to you at 30 weeks gestational age. She is G3P2LO. There was an IUD at term and the other child died suddenly at 10 months of age. You notice 2:1 AV block. Will you start salbutamol for the mother? Yes or no? These are the 5 questions we are showing it in Zoom platform. I hope other people who joined through Facebook and YouTube can, they also came to know these questions. So I think more than 70% of the people have voted these questions. Can we end polling, sir?
Yes, I think we can.
I will end polling now. So we will do the polling once again at the end of the session. You can revise what answers you have given. I am ending poll. Sir, you can proceed.
How do I remove the poll from my screen?
Just minimize that polls or close it. That polls screen.
Yeah, I got it. Thank you. So with that, we'll move on to the individual arrhythmias. And to start with the paroxysmal events. Now, the paroxysmal events, a vast majority are premature atrial complexes. So as I said, every atrial contraction is usually followed by a ventricular contraction, and which is the atrial activity is regular and the ventricular activity is regular as well. Now, premature atrial complexes happen a bit earlier than they are supposed to. So you will see transient irregularity in the heart rate when you do an umbilical artery Doppler. And when you do an inflow-outflow Doppler, you will realize that the atrium occurs a bit earlier than when it is supposed to occur. Now, these are of two types. They can be conducted in that the premature atrial contraction will be followed by a ventricular contraction as well, or they can be non-conducted. which means that the atrial contraction is not followed by a ventricular contraction. So how do you differentiate the two of them? If you measure the heart rate only by means of the umbilical artery Doppler, you will find one contraction occurring slightly earlier than usual in a conducted PAC. Whereas if it is a non-conducted PAC, you will find that there is one missed beat, or there is one gap which is double the normal gap between two contractions. Now, if you want to be sure about the mechanism, as I said, you have to do an inflow-outflow Doppler. I'm going to show pictures of it here. So this is an umbilical artery Doppler of a PAC. You can clearly see that there is irregularity in the heart rate. So there is one beat or one output which occurs earlier than normal, and this occurs alternately. So these are premature atrial complexes in a bigemini fashion, or every alternate contraction is because of a premature atrial complex. If you were to do an inflow-outflow Doppler, you will realize that the PAC occurs earlier than usual on the ventricular inflow. And if it is followed by an output trace, then it is a conducted premature atrial complex. But if it is not followed by an output trace, it is a non-conducted atrial complex. So what is the importance of them? They are the commonest arrhythmias you see, but a vast majority are benign and do not need any further evaluation or treatment. But it is important to remember that frequent premature atrial complexes carry a small risk of developing tachyarrhythmias, and you need to hence keep a slightly close eye on these fetuses. So if you are doing growth scans every 4 weeks or so, at least in the early period, it might be worthwhile doing it slightly more frequently to make sure that you don't miss a tachyarrhythmia. And it's also important to rule out associated structural heart disease, even though they are not very common. We'll then move on to the bradyarrhythmias, or the slow heart rates. Now, this is how we classify bradyarrhythmias in the fetus. And I recognize this is a slightly complex slide. So I'm going to make it simple. I'm going to discuss only 3 arrhythmias. They are sinus bradycardia, 2:1 AV block, and complete heart block. And the way to differentiate them is only by looking at the AV relationship. So in complete heart block, the atrium contracts, but the atrial activity is not conducted down to the ventricles because the AV node is not functioning. So the ventricle needs to contract on its own. And there is no interchange of information or no talk between the atrium and the ventricle. So the atrium has a mind of its own and the ventricle has a mind of its own. But unfortunately, the ventricle is not capable of contracting at the same speed as the atrium. So you will see that the atrium contracts much faster, but the ventricle contracts in a much slower rate. And there's absolutely no correlation between the two of them. So if you have sinus bradycardia, you will realize that the heart rate is lower than normal, but that every atrial contraction is followed by a ventricular contraction. In 2:1 AV block, you will find that the atrium contracts normally, but only alternate atrial contraction is followed by a ventricular contraction. So the atrial rate will be normal, but the ventricular rate will be half the atrial rate. In complete heart block, the atrium will be contracting at a normal rate and regularly, but the ventricle will be contracting at a much lower rate, and there will be no clear pattern of association between the atrium and the ventricle. So sinus bradycardia, your atrial rate is low, your ventricular rate is low, but they are both the same. But complete heart block, your atrial rate is normal, the ventricular rate is very low, and there is no correlation between the atrium and the ventricle. I'm going to show a few examples after discussing these conditions, where it will be clear to you how to differentiate it on the M mode. But before that, I'd just like to explain in greater detail about fetal complete heart block. You divide that into isolated, where there is no structural heart disease, and those with congenital heart disease. Those with congenital heart disease typically have an early presentation. That is, you will see a low heart rate in the first trimester or even early in the second trimester. And their prognosis and outcome depend on the associated structural heart disease. Now, the isolated complete heart block, a vast majority of them are associated with maternal autoimmune disorders, specifically positivity for SSA and SSB antibodies. They have a slightly later onset. So the onset is usually in the mid to late second trimester, even though onset as early as 16 weeks has been documented. If you look at prognostic factors, associated structural heart disease generally has a very poor prognosis, and that is because most of these heart diseases are complex heart diseases, whereas isolated heart block generally has a favorable prognosis. If you look at isolated fetal heart block, if after delivery, the neonates live beyond the neonatal period, then later attrition is extremely rare. So the risk of death is highest in the fetal or neonatal period. But once they go beyond the neonatal period, they generally do very well. And what are the risk factors for poor outcome? If the onset is very early, say you see heart block before 20 weeks, if the ventricular rate is consistently below 50 per minute, if you see hydrops fetalis, or if you can see impaired LV contractility on ultrasound, then these are some of the high risk factors. Which is why earlier recommendations said you have to start dexamethasone for all of them, as long, even if the heart rate is more than 55 per minute, to prevent the heart rate from coming down and to maintain ventricular function. But now, after the PRIDE study, which was a sort of non-randomized trial at a reasonably large number of patients who were treated with dexamethasone or not treated with it, they were able to find that dexamethasone had absolutely no improvement in those who had established heart block, whereas a lot of them tend to have complications related to the steroid use. So in most of the centers, they do not use steroids for fetuses with complete heart block. So what is a reasonable protocol is, if you have a mother with known antibody positivity, starting from 16 weeks, you do weekly ultrasounds and you look specifically for the AV interval. So heart block usually has a progression. To start with, there is increase in AV interval, and then slowly it proceeds to complete heart block. People have used steroids and hydroxychloroquine at an early stage before you see complete heart block, but then the risk benefit has to be discussed with the family, and then a decision has to be taken. Now, fetuses with established complete heart block, there is no role for steroid, hydroxychloroquine, or IVIG therapy. What you can do is a weekly monitoring of heart rate, fetal growth, and ventricular function. And if the heart rate is persistently less than 50 per minute, then the only drug which has been shown to have some benefit is salbutamol therapy. So this is how we look at AV interval. So you can look at it either in the inflow-outflow Doppler or in the pulmonary artery, pulmonary vein Doppler. And the interval you measure is from the start of the A wave to the start of the V wave. And if it progresses beyond 70 or 80 milliseconds, then you start thinking of increasing first degree heart block. So what I do is, if the ventricular rate remains above 50, then I follow them up to term and deliver them at term. And at any point earlier, if they tend to develop hydrops or a lot of ventricular ectopics, then you will have to deliver them early, even if the rate is good. Now, if the ventricular rate is less than 50 per minute, I start them on salbutamol and follow them up to term when I deliver them. But if I start seeing high drops, despite salbutamol therapy, I tend to deliver them early. Now, the problem with delivery is, how do you assess fetal distress? You cannot go by a non-stress test because the fetal heart rate is low to start with, and there is no fetal heart rate reactivity. So the fetal heart rate does not, undergo the normal accelerations and decelerations which you see in fetuses. And because the heart rate is low, all your Doppler velocities are much higher than normal. So you cannot rely on pulsatility index of the middle cerebral artery in these cases. The velocities are usually much higher than what you see in a normal fetus. So the rules of decision making for fetal distress in a normal fetus do not apply in complete heart block. So what we use is the CPS, or the cardiovascular risk profile score, which looks at 5 specific points: the presence of high drops, the umbilical venous Doppler, the size of the heart, the cardiac contractility, and the umbilical artery Doppler. And increasing points gives you a clue about a Doppler, about the fetal growth restriction. So I'll demonstrate what I talked about by a case study here. This is a 25-year-old primary mother, non-consanguineous marriage, who had an uneventful pregnancy till 20 weeks. But then when she came back for 28 weeks, she was noticed to have a low heart rate on a routine scan. And this was what we saw on 2D ultrasound. Do all of you agree that the heart rate is low? Is there any other finding here which is worrisome for you? So there is some degree of cardiomegaly, and there is pericardial effusion as well. So when you look at the heart, atrial and the ventricular heart rate, they seem to be different to each other. And I'm going to show you a better. So you can see that we are cutting. So this is an M mode, and you're cutting first through the ventricle and then through the atrium and then the ventricle. And you can see that the atrial rate is much higher than the ventricular rate. So the atrial rate in this is 131 and the ventricular rate is only 43. And when we assess the growth of the fetus, it was at the lower centile. So there was growth restriction. So what we did was we hospitalized this patient and started him on beta agonists. So the dose which we start on typically, and I can notice in the chat that someone had asked about the dose of salbutamol, is 4 milligram 3 times daily. We then monitor for maternal symptoms like palpitation and tremors, and we monitor the fetal heart rate twice weekly. And when we saw this child a week later, you could see that the heart rate had already improved to 52 per minute. And there was also some improvement in the growth centile. So they had moved from the 4th centile to close to the 20th centile. So within a week, there was an improvement in heart rate and there was an improvement in growth as well. But 3 weeks later, when we saw the fetus again, the heart rate had dipped to 45 per minute. Now, why does this happen? Now, to understand why that happens, we have to go back to our pharmacology and understand a phenomena called tachyphylaxis. In the sense, if you give a drug repeatedly, the efficacy of the drug tends to go down with time. And how do you improve the efficacy of the drug when it has gone down? You do it by increasing the dose of the drug. So we had to do this multiple times in this fetus. And we actually had to go up to the maximal permissible dose of salbutamol, which is 10 milligrams 6th hourly, or a total of 40 milligrams per day. And because this dose is spread across both the fetus and the mother and the fetus, and the circulating blood volume is very large, you will notice that mothers typically tolerate this drug very well. So whenever you increase the dose, they may have tremors or anxiety for the first 1 or 2 doses, but within a day, the symptoms subside and mothers tolerate it very well generally. So I can remember only one case where we had to stop salbutamol because the mother really did not tolerate the drug, but a vast majority tolerate this very high dose well. So with that, we were able to deliver the fetus at term and take an ECG, which showed that the ventricular rate was very low, 40 per minute, and there was features of complete heart block. So we immediately got an umbilical venous line and gave isoprenaline infusion through it, which resulted in an immediate improvement in heart rate to 70 per minute. And we were able to transition this child to insertion of a permanent pacemaker. And this is the rhythm after insertion of the pacemaker. You can see that the rate has gone up to 70. And the child is actually doing very well. This is a recent picture. The child is now 9 months old and growing normally with no major issues at all. So for the next scenario, I'm going to deviate a bit from fetal arrhythmias. And this might be of interest to obstetricians as well. This is a primigravida, married for less than a year and with a natural conception. The mother was diagnosed to have complete heart block and underwent a pacemaker implantation at 18 years of age. She had an ultrasound elsewhere, which has shown oligohydramnios, but normal growth at 26 weeks gestation age. At 27 weeks, decreased fetal movements were noticed, and an ultrasound at that time had shown, again, oligohydramnios, but normal growth. When they came to us 2 weeks later, 29 weeks, the fetal movements had been reduced for 3 weeks. And when we did it, the fetal heart rate was normal. The biometry, all the parameters were at the lower level of normal, that is between 5 to 10%. But the Dopplers were all at that stage normal. So what we have here is fetal growth restriction. So what do you want to do? Do you want to deliver the fetus now? Or do you want to closely follow the fetus and deliver it if the Dopplers become abnormal? So delivery now or delivery? So I can see that someone is saying Doppler, if Doppler is abnormal, they'll deliver and they'll follow up till that stage. Is there something we are missing here? So we have a mother with heart block and a fetus which has suddenly stopped growing. Is there something else which you think we are missing? Now, when the mother's heart rate was checked, the heart rate was only 60 per minute. And why is the heart rate low for the mother? It is because the pacemaker has been set at 16. And because the mother has complete heart block, her heart rate cannot go beyond what is the set heart rate for this mother. And pregnancy, typically, you need to increase the cardiac output. And the one way of doing that is by increasing the maternal heart rate. And what you need to do is to set the pacemaker to a slightly higher rate. Now, in this particular case, the only intervention we did was increase the pacemaker rate from 60 to 80, and within 2 weeks, the growth had started catching up. So it is important to not just look only at the fetus, but also to look at the mother and the fetus as one whole unit. Now with that, I'll move on to the next case study on Bradyarrhythmias. So this is a G3P2L0 mother who was referred to us at 24 weeks because someone had seen low heart rate. The obstetric history, the first pregnancy had resulted in an intrauterine death at term. And the second pregnancy had essentially been uneventful, but the infant had died suddenly and in unclear circumstances at 3 months of age. We did a fetal echo at 25 weeks, and the only thing which we found was a slightly lower than normal heart rate. The heart rate was consistently between 104 to 115 per minute, and there was a very small pericardial effusion. But when we looked at the M mode, there was 1:1 AV conduction. So we knew that we were dealing with sinus bradycardia. But because there was a small pericardial effusion, we reassured the mother to keep a close. We did file just to show all negative. Guys review after 4 weeks. And when they came to us at 28 weeks, heart rate is only 60 per minute on the outflow Doppler. But when we did an M mode, so you can see the M mode is cutting through the atrium first and then the ventricle. So the contraction which you see on top is the atrial contraction, whereas the contraction which you see in the bottom is the ventricular contraction. So the it's only every alternate atrial contraction which is followed by a ventricular contraction. So this A is followed by a V, this A is not followed by a V, and this A is followed by a V. And the atrial rate is exactly double the ventricular rate. So what we have, what are the findings we have? We have a low heart rate and we have 2:1 AV conduction, which is 2:1 AV block. So because the ventricular rate was 60, we did not start any medications for this mother. And we were safely able to follow her up to term and deliver her. And when we delivered the baby and got an ECG, we were in for a surprise. So you can see P waves and QRS complexes. So every P wave is not followed by a QRS complexes. So it's only alternate P waves which are followed by QRS complexes. So it's only alternate P waves which are followed by QRS complexes here. But then there is something unusual about this ECG. What are the waves we know of in an ECG? We know of a P wave, a QRS complex, and a T wave. And where do you see the T wave in this ECG? You can see that the T wave is very far away. In fact, it occurs after the second P wave, which is not conducted. And this feature suggests prolonged QT interval. And this is another ECG from the same child when the heart rate was slightly higher. So you can see that the QT interval is more than half the RR interval. And this feature is typical of long QT syndrome, which is a congenital disorder. The QT interval in this case was 630 milliseconds, whereas the normal QT interval is usually less than 450 milliseconds. So this is significantly prolonged. And when we looked at genetic testing, we found a pathogenic mutation in one of the long QT genes. So one of the important take-home messages in this is if we had started this mother on salbutamol, we could actually have resulted in intrauterine death because beta agonists increase the risk of arrhythmias in long QT syndrome. So when will you think of long QT or other unusual arrhythmias in the fetal period? The most important point to make you think of this is family history. So if you have family history of unexplained deaths in multiple family members or a very bad obstetric history, your suspicion should increase, especially when the circumstances of death are not very clear or if they are associated with exertion. One feature which we see commonly is sinus bradycardia. Now, fetuses, as we all know, can normally have sinus bradycardia or a slightly low heart rate intermittently. But then there is a beat-to-beat variability. So the heart rate can go down as low as 80 normally, but if you look at the heart rate, at different intervals, they tend to vary. So they can go up to 90, then 110 or even 130. Whereas in long QT and other channelopathies, there is very minimal variability. So the heart rate in multiple settings tends to be on the lower side or low normal, say between 100 to 120. And when you see persistent 2:1 AV block, especially when the mother is antibody negative, in the sense she does not have SSA and SSB antibody, then you think of long QT syndrome. So a bad family history of sudden unexplained death, sinus bradycardia but with very minimal variability on heart rate, and 2:1 AV block in an antibody negative mother are settings where you think of long QT syndrome. With that, we'll move on to tachyarrhythmias. And before that, I'd just like to check, are all of you able to follow me? Okay. So the problem with tachyarrhythmias is similar to what we have with the GIF you're seeing on your scene. If I make you run on the treadmill for a minute, all of you will be comfortable. If I make you run for 10 minutes, some of you may be comfortable, especially those of you who run regularly. But if I make you run for hours and hours, you're going to fall down. And that is the problem with tachyarrhythmias per se. When the heart beats at a very high rate for a long time, the heart tires out and it develops ventricular dysfunction. So the presentation of fetal tachyarrhythmias can be with a fast heart rate alone, but especially if it's long-standing, you can only see poor ventricular function or features suggestive of non-immune fetal hydrops. The heart rate at points might be normal, but you should remember that you're monitoring the heart rate for a very short period, say half an hour. So that might be a short period when the tachycardia is not happening. So when you see poor ventricular function and when you see non-immune fetal hydrops, then tachyarrhythmias should be in the back of your mind as one of the differential diagnoses. Now the classification is very complex. It includes ventricular tachycardia, supraventricular tachycardia, atrial flutter, ectopic atrial tachycardia, junctional ectopic tachycardia, permanent junctional reciprocating tachycardia. I don't want to intimidate you by giving you all of these. I want you to focus only on two of these. The atrioventricular reentrant tachycardias, or what we call the SVTs, and atrial flutter. These constitute more than 90% of significant tachyarrhythmias in the fetus. And the management across these various types do not differ greatly. The importance of recognizing atrial ectopic and permanent junctional reciprocating tachycardia is that they tend to be very incessant and the prognosis in the postnatal life might vary, but during antenatal management, it does not vary much. Before we understand how these arrhythmias occur, it is important to understand what is the mechanism of these arrhythmias. The SVT is essentially a reentrant arrhythmia. So the atrial signal passes down through the AV node to the ventricle, but then goes back into the atrium through an accessory pathway, and then comes down to the ventricle again through the AV node. So there is essentially a circus movement. But what you can recognize here is that every atrial activity is followed by a ventricular activity. So there is 1:1 AV relationship. Flutter is an arrhythmia which occurs within the atrium and may or may not be conducted down to the ventricle. So in AV reentrant tachycardia, every atrial activity is followed by a ventricular activity. And the rates are very high. They are usually more than 180 per minute and typically more than 220 per minute. Whereas in atrial flutter, the atrial rate is much higher. It is usually between 300 to 500 per minute. But not every atrial activity is conducted down to the ventricle. So the ventricular rate is usually in a half the atrial rate. So if the ventricular rate is 300, the ventricular rate is usually around 150. You can also have 1:1 conduction or 3:1 conduction or 4:1 conduction, but the commonest is 2:1. So when you do an M mode, every 2 atrial activity is followed by a ventricular activity, similar to what you see in 2:1 AV block. But the rates are very, very high in this setting. So the atrial rates are typically between 300 to 500, whereas the ventricular rates are usually between 150 to 250. So the only thing you need to look for to differentiate these two common arrhythmias is to look at the AV relationship. If you see a tachycardia with 1:1 AV relationship, it is SVT. Whereas if you see a tachycardia with 2:1 or 3:1 AV relationship, it is atrial flutter. Now, sinus tachycardia also has 1:1 AV relationship, but sinus tachycardia almost never goes above 220. So if you see a tachyarrhythmia with a heart rate of more than 220, it is SVT. So what are the management options? You typically have 4 management options. The first is watchful expectancy, which is not doing anything. The second is to deliver and treat. The third is transplacental therapy. And the fourth is direct fetal therapy. If the tachyarrhythmia is sustained, then the child is going to fall off the treadmill. And so watchful expectancy is not really a good idea. Deliver and treat is the best option for term babies because it's much easier to give the drug directly to the baby than to give it through the mother. And term babies, you are not going to achieve anything by trying to control the heart rate inside the mother. In late preterm babies, if you have a good NICU setting, it might be reasonable to actually deliver the baby and treat the baby instead of trying to treat the fetus. Transplacental therapy is therapy to the mother, which then goes through the placental circulation to the fetus. And this is the first choice of therapy in most fetal tachyarrhythmias. In selected cases, you might have to directly treat the fetus. The choice of agents and the routes I'm going to discuss in the next few slides. The choice of drug with regards to transplacental therapy is essentially a balancing drug or act. You need to balance the safety of the drug in that it should not harm the fetus or the mother against the efficacy of the drug. And the common drugs which we use are sotalol, flecainide, and amiodarone. Now, interestingly, these drugs have a graded safety profile as well as efficacy profile. Sotalol is probably the safest of these individual agents, but efficacy-wise, it's probably slightly less efficacious than the other 2 agents. Flecainide is a bit more efficacious than sotalol, but the toxicity profile also increases proportionately, whereas amiodarone, which is reasonably, which probably has the highest efficacy of all these drugs, also has the highest toxicity as well. You will notice that digoxin, which was the drug chosen by a number of people in the poll, is not mentioned in this list. And that is because in this day and age, monotherapy with digoxin for any fetal tachyarrhythmia is not a good idea at all. Digoxin only works in reentrant arrhythmias, and it is much less efficacious than these agents. And I would not start monotherapy with digoxin in a fetus with tachyarrhythmia. Digoxin can be used as an additional agent if you're not able to achieve enough activity enough control with your primary drug, but I will not give digoxin as a monotherapy in an important fetal tachyarrhythmia. I'm going to concentrate on sotalol. As I said, it's the least efficacious, but it also has the best safety profile. And it is emerging as the drug of choice, as the first-line drug of choice in most fetal tachyarrhythmias worldwide. It is my personal preference as well. And this study, which was the largest initial study to look at the efficacy of sotalol, found that even with the presence of eye drops, sotalol resulted in control of the arrhythmia in most cases. So what is the dose you start with? So for sotalol, the typical dose which I start with is 40 milligram thrice daily. I give at least 3 doses which occurs over a day and look for response. And then if there is no response, I slowly increase it to a maximum of 160 milligram thrice daily, or a total dose of 480 milligram. And if at the end of this maximal dose, if I don't see a response, I add a second agent. Now the dose of sotalol which the adult cardiologist will give to an adult is probably between 80 milligram BD to TDS. So I'm giving close to 2 to 3 times this dose in the mother. And it is important to look for maternal toxicity. And the way I look for you look for maternal toxicity is by measuring the QTC interval. So if you see an increase in QTC interval beyond 480 milliseconds, then you need to decrease the dose of the drug. Now, even though I'm using a dose which is extremely high, I almost never see a problem with QTC in mothers, even at such high doses. And that is because the volume of distribution of the drug is very high in a pregnant mother. So it is distributed over both the increased blood volume of the mother as well as the placental circulation. And that is one of the reasons why you never see a toxicity of, almost never see a toxicity of sotalol. But it's important to remember that this can occur and that you should monitor for this. The next drug is digoxin. Now, when I add digoxin as a second agent, I usually do not bother about IV digitalization. And I just start only a maintenance dose. 0.25 milligram TDS is what I start with, and I go up to 0.5 milligram thrice daily to 6th hourly. The way to monitor digoxin therapy is by serum digoxin concentrations. It is important to look for serum digoxin concentrations when you give IV digoxin, but at the levels of oral, at the dosages of oral digoxin which we typically give, the chance of toxicity are next to nil, and I do not bother with serum digoxin levels which are cumbersome to get in this subset. The other agent which we commonly use is flecainide. And flecainide we start at a dose of 100 milligram BD and sometimes go up to as high as 150 milligram thrice daily. With flecainide, toxicity is a problem, and it is important to monitor for toxicity. In the West, they do it by serum flecainide levels. To the best of my knowledge, serum flecainide levels are not available in India. But thankfully, we have a very beautiful surrogate marker for flecainide toxicity in the absence of flecainide levels. And that is measuring the QRS interval, or the duration of the QRS complex on the ECG. And if it goes above 110 milliseconds, then you know that there is a very high risk for flecainide toxicity. Again, as I said with sotalol, even though we give a dose which is much higher than what you typically use in adults, you do not see toxicity very commonly because of the increased volume of distribution. But then given that this is a very toxic drug, it is important to keep a close eye. With IV digoxin, I very rarely use it these days, but it's important to know it. What you do is you give 1,250 micrograms over 24 hours. You mix 250 micrograms in 100 ml of NS and then give it as a slow IV with a total of 6 doses. And it's important to remember that you should try to measure serum digoxin concentrations whenever you give an IV loading dose of digoxin. Direct fetal therapy is rarely used in selected cases when there is not enough response to the drug use and when there is hydrops as well. What you do is you give the drug intramuscularly in the case of digoxin. So you go through the placenta and try to give it in the fetal thigh. You can see this is the fetal thigh and this is where the injection is coming in. The dosage is 88 microgram per kilogram of the estimated fetal weight. And I think you guys as fetal medicine specialists and obstetricians are much better at interventional fetal interventions than we are. And I tend to do all of my direct fetal therapies along with my fetal medicine team. It's important to recognize tachyarrhythmias because they have excellent postnatal outcomes if we recognize and treat it. So to the right of the slide is our experience at Amrita, where over an 8-year period we had treated 18 fetuses with tachyarrhythmias, and all of them survived and were safe. There was 100% survival, and all of them had good response to treatment on follow-up. And that is the experience worldwide as well. So if you recognize it early and treat it in the correct time, you have universally very good outcomes. So I'll try to explain this by 2 case studies. The first is a primigravida with no family history of heart ailments who had a normal anomaly scan at 20 weeks of gestational age. But during a routine growth scan, the fetal heart rate was noticed to be very high. So looking at this image, you know that the fetal heart rate is high and that there is significant tachyarrhythmia. And when you do an umbilical Doppler, you can see that the fetal heart rate is 220 per minute. Again, between 215 to 220. And when we did an MO, so you can see that I'm cutting through first the ventricle and then the atrium. So the activity I see on the top is the ventricular activity, and the activity I see at the bottom is the atrial activity. So you can see that every atrial activity has a corresponding ventricular activity. So the atrial activity, ventricular activity, A, V, A, V, A, V. So it is regular. And the atrial heart rate and the ventricular heart rate are the same. So when I check it at a different time period and with different sweep speeds, it is the same again. So what we have here is high heart rate and 1:1 conduction, but I do not see any feature to suggest high drops. There is no ascites and no pericardial effusion. So what do you think is the diagnosis here? So AVRT or SVT. So the diagnosis is very clear. This is SVT, and the management plan was to start antiarrhythmics for the mother. So as I said, the drug which you give supports not only the maternal circulation but also the placental circulation, and so the dosage of the drug is much higher than what you typically use. So we started at 40 milligram thrice daily and then slowly went up to 160 milligram thrice daily. We carefully monitored for maternal toxicity by using ECGs to calculate the QTC interval. And despite the very high doses, there was no evidence of maternal toxicity. And frequently monitor the child for rate and rhythm control. And once we got on top of it, you still need to follow them up at least weekly to make sure there are no recurrences. The baby was then delivered at term. The birth weight was 2.5 kilograms, and the baby was sinus rhythm at birth. But because there was a long period of tachyarrhythmia, we gave prophylactic beta blockers for the baby for 3 months. But the baby continued to remain well and asymptomatic. And this is the baby at 2 months of age. You can see the baby is really happy with no concerns at all. Now going on to my second case scenario. This is a 30-week mother who's gravid at 2 with live 1 child. You can see definitely from the video on the left of the screen that there is a fast heart rate and there is some evidence of fluid around the body. There is pericardial effusion. And on color Doppler, you can see regurgitation of both the tricuspid valve and the mitral valve as well. On a pulse wave Doppler, the heart rate was 250 per minute. And when we got an M mode, so we are cutting through one atrium and a ventricle. So the atrium is on top and the ventricle is on the bottom. So the activity you see on the top is the atrial activity and the activity you see on the bottom is the ventricular activity. So you can see that it's only alternate atrial activity A wave, which is followed by a V wave. So, and when you calculate it, the atrial rate is probably around 500, whereas the ventricular rate is close to 250. So what do you see? You see there's also ascites and pericardial effusion. So what you see is high heart rate at 2:1 conduction and ascites as well as pericardial effusion. So this is atrial flutter with 2:1 AV block, as everyone had rightly provided in the chat box. And the treatment for it, now personally, I tend to start only transplacental therapy even if there is hydrops. But because there is hydrops, I usually start with a much higher dose. So if I were to choose sotalol, I will start with probably 80 to 120 milligram thrice daily. Or if my agent of choice were flecainide, I'll probably start at 100 milligram thrice daily. Watching for maternal toxicity, and I will consider direct fetal therapy only if there is no adequate response to therapy. Because digoxin generally does not have much activity in flutter. So I will probably in flutter pursue with transplacental therapy longer before considering direct fetal therapy. Whereas my threshold for direct fetal therapy might be slightly lower in SVTs. So with that, I come to the end of my talk, and I'm happy to take your questions here. I'll go through all the questions which I have in the chat box. Someone has asked, can I get PR interval from renal artery and renal vein? Unfortunately, no, it is only with the inflow-outflow Doppler that you can get AV interval. The renal artery and vein are too far away from the heart, and the cardiac activities may not be transmitted to the renal vein. So if you want to look at AV interval, you have to get a SVC aorta Doppler, a LV inflow-outflow Doppler, or a pulmonary artery, pulmonary vein Doppler. Even a ductus venosus does not get the reflected atrial activity, and you may not be able to interpret AV based on the renal artery and renal vein. Can you explain M mode again? I'll go back to my slide on M mode. So the important thing in M mode is to align your M mode in such a way that it cuts through one atrium and one ventricle. It does not matter that you should cut through the atrium and ventricle of the same side. So you can cut through the right atrium and the left ventricle as we have done in this case. And you can see atrial contraction as well as ventricular contraction. So in your image above, the atrium is on top and the ventricle is on at the bottom. So the M mode trace which you see in the top is that of the atrium, and the M mode activity which you see on the bottom is that of the ventricle. And most advanced ultrasound machines nowadays allow you to calculate the atrial rate separately and the ventricular rate separately. So here, because the heart rate is normal, you can trace that every A wave is followed by a V wave. But sometimes in very fast heart rates, it may not be easy to follow this 1:1 relationship, and you can measure the heart rate. And here you can see that the atrial and ventricular heart rates are very much the same. I hope that explains your doubt about the M mode. What is the earliest gestational age at which arrhythmias can be detected? With heart block, isolated heart block, it is usually in the mid to late second trimester, so between 20 to 28 weeks, although sometimes it can occur as early as 16 weeks. With your tachyarrhythmias, they almost exclusively occur in the third trimester. How to differentiate between 2:1 heart block and PACs? That is a very good question. So PACs in a bigeminy fashion non-conducted PACs in a bigeminy fashion can mimic 2:1 block. But then the atrial activity in 2:1 block is always regular. Whereas in PACs, the hallmark of PACs is irregularity. So if your A waves are regular, then it is 2:1 AV block. But if the A waves are irregular, then it is non-conducted PACs in a bigemini fashion. So how to differentiate block PACs from complete heart block? So again, in complete heart block, the atrial activity will be regular, whereas in block PACs, the atrial activity will not be regular. The same question, how to differentiate between atrial bigeminy and 2:1 heart block? It is by looking at irregularity of the atrial activity. Does AV interval represent mechanical PR interval? Yes, it does. It does not measure the actual PR interval. It is indeed a mechanical AV PR interval. The next question, how do you optimize M mode? The way to optimize M mode is to cut through the atrium and ventricle properly. So that you are able to follow the contractions well. So you just have to align the atrium and ventricle correctly, and that is the only way you optimize M mode. What is the dose of salbutamol you use? I think I discussed it in the case. So I tend to start at 4 milligram thrice daily, and then increase it slowly to a maximum of 10 milligram sixth hourly or 40 milligram per day. Can you show the slide on management of heart block? I'll get to it in a second. So what I do is, if the ventricular rate is more than 50 per minute, I follow them up and deliver a term. But if the ventricular rate is less than 50, I start salbutamol. And if there is evidence of fetal abnormality like high drops, then I tend to deliver them early. When we give salbutamol for complete heart block, we give it continuously, or intervals in between. No, we give it continuously. As I said, pregnant mothers tend to tolerate it very well. How do you interpret ductus venosus waveforms in complete heart block? That is a very good question. Unfortunately, you cannot go by A wave reversals in the ductus venosus in complete heart blocks. That is because of the AV dissociation, you can see giant intermittent A reversals in the ductus venosus. And that is why we do not go by only the ductus venosus. We have the cardiovascular risk profile score, which looks at 5 different entities. And we use a combination of these to decide on outcomes and do not go only by the ductus venosus. Which type of antibody fetus should you do in fetal bradycardia? You should do both SSA and SSB, although SSA probably has a much higher association than SSB. So, do we see sinus tachycardia if a mother presents with fetus and when to ask for follow-up scan? I will probably do it at a week's time. I don't think there is any guideline for that per se, but I think if there is no high drops and everything else about fetal growth is normal, I'll probably see them in a week. And again, such patients do not come to me because I'm a cardiologist, and so fetal medicine people in this forum might be better at answering it than me. What percentage of fetal arrhythmias, how often can, so 2% is what is the general rule, but a vast majority of them are benign. Can you explain once again blocked and conducted PAC? So if the atrial activity, if the PAC is followed by a ventricular contraction, then it is a conducted PAC. Whereas if the premature atrial complex is not followed by a ventricular contraction, it's a blocked PAC. Will you elaborate on M mode evaluation in fetal echocardiography with typical views? Unfortunately, I'm sorry, I am not aware of the, I think a four-chamber, lateral four-chamber view or an oblique four-chamber view is what is needed for M mode. All you need to do is make sure that, sorry, I'll just go back to the M mode again. All you need to know is, all you need to ensure is that the M mode cuts through one atrium and one ventricle. It does not matter what you use, as long as it cuts through one atrium and one ventricle, you will get the information you need. Re-explain conducted and non-conducted PACs. I've done that again, I hope. So what protocol to follow for arrhythmia? Again, it varies between tachyarrhythmia and bradyarrhythmia. Can you explain the role of AV and VA interval in SVT? I specifically did not explain this because I wanted to stick to the basics, but I do have a slide on it and I can show it to you. So you look at the AV interval by looking by the pulmonary artery, pulmonary vein Doppler or the SVC aorta Doppler. Most fetal medicine specialists tend to prefer the SVC aorta Doppler, but my personal preference is to get a pulmonary artery, pulmonary vein Doppler because of the simple reason that it is easier to get a pulmonary artery, pulmonary vein Doppler than it is to get a SVC aorta Doppler. So this is a pulmonary vein, pulmonary artery Doppler. So the pulmonary vein shows a forward flow into the atrium and intermittent reverse flow, which is what we call a wave. Why does the A wave occur? It is because whenever the atrium contracts, it pushes some blood back into the pulmonary veins. So this is what we call A reversal. And the pulmonary artery tracing which you see is the ventricular contraction or the equivalent of the V wave. So you can see V and A. Now we measure VA interval. And if it is less than half the VV interval, we call it as a short VA tachycardia. Whereas if it is more than half the VV interval, we call it as the long VA tachycardia. Short your SVTs, AVRT, are short VA tachycardias, whereas ectopic atrial tachycardia and PJRT are long VA tachycardias. Why is it important to differentiate between them? Even though the initial treatment between the two does not vary, SVTs are usually easier to control, whereas EAT and PJRT are more difficult to control. And after birth, the risk of recurrences with SVT is very low, whereas the risk of recurrences even after birth is very high with the other tachyarrhythmias. So if you're able to identify this mechanism, It allows you to counsel the families appropriately and also allows you to monitor them much more closely. So that is the importance of VA interval in SVT, to differentiate whether this is a short VA tachycardia or a long VA tachycardia. In atrial flutter, may it require repeated direct therapy? Generally, no. You almost never need to repeat direct fetal therapy. And as I mentioned, digoxin's efficacy in flutter is much lesser than what it is in SVTs. People have also tried fetal therapy with amiodarone intravenously. I've never had to do it. And I think you only need to do it in exceptional circumstances. And because most of these tachyarrhythmias tend to occur late in the third trimester, it might actually be a better idea to deliver the fetus and treat the newborn baby than to go for repeated fetal therapy. So I don't see any advantage in giving direct fetal therapy more than one time. Why Tachyarrhythmias are preceded by transient Bradyarrhythmias or PACs? Yes, you are indeed right. Most of the reentrant arrhythmias, not the flutters, are preceded by PACs. In the sense, the PACs are what set in motion the circus movement which we saw. So I'll go back to my slide on the mechanism of SVT. And these circus movements which you see are usually triggered by a PAC. I don't want to go into the depths of the electrophysiological reasons for why this occurs, but you are right. And that is why one of the reasons why we say if you see very frequent PACs, you keep an eye on there is a slightly higher risk for developing tachyarrhythmias in the future. Please explain PR interval calculation. So again, we do not calculate PR interval. What we calculate is the AV interval. And that is one of the ways you monitor a fetus who's at high risk for complete heart block. So you do it by two ways. You either get a pulmonary artery, pulmonary vein Doppler, or you get a ventricular inflow-outflow Doppler. So the Doppler you see on the left is an inflow-outflow Doppler. And you measure the time interval from the start of the A wave, which is the second wave in the inflow Doppler, to the start of the V wave, which is the outflow Doppler. So in the slide here, the interval from this point to this point is the AV interval. Somebody has said, kindly provide answers for your quiz and discuss. So we will go back to that in a second. How to interpret umbilical artery, MCA, and ductus Doppler in fetal heart block. As I said, you cannot go by these Dopplers in IUGR to plan delivery. That is because the Doppler velocity is dependent on the amount of blood going through. And when you have bradycardia, the amount of blood which is pumped out by the heart in each contraction is more than normal. So you have a much higher velocity and your pulsatility and resistance index are different. So you cannot make decisions purely by your umbilical artery, MCA, and ductus Doppler, which is the reason why we use the cardiovascular risk profile. How much difference in atrial and ventricular rate is accepted as normal? Actually, there is no difference. The difference you see is because it is almost impossible to keep the so I'll show you. I'll explain this with an example here. So you can see that very clearly that every atrial activity is followed by a ventricular activity, and that 1:1 AV relationship is there. But when you measure the heart rate, you find a difference. And that is purely because it is very difficult for you to keep the heart rate traces at the same point in each activity. So it is very unusual for you to find differences about 10 beats per minute. The difference here is slightly higher, and that is because I've been a bit casual about placing my points. And the error is only because we don't place it properly. It's not because there's an actual difference in the rate. So anything more than, anything less than 10, I wouldn't bother about it. Most common congenital heart block is CCTGA. No, it's actually the most common congenital heart block is isolated CHB due to maternal antibodies. It is not CCTGA. CCTGA is probably a smaller number. And it's important to recognize that even those with CCTGA, the risk of developing heart block postnatally is higher than that antenatally. So the commonest cause is not CCTGA, it is isolated heart block due to maternal antibodies. Mother with a known case of Sjogren's syndrome, fetus at 22 weeks with a fetal heart rate of 54 to 80 per minute. How to further manage? Previous termination of pregnancy at 20 weeks for the same issue. Termination of pregnancy does not solve your problem in Sjogren's syndrome, because with every subsequent pregnancies, the risk goes up. So for the first pregnancy, the risk is in the order of 3 to 5%. For subsequent pregnancies, and especially if more than 2 fetuses are involved, the risk is as high as 50%. So as long as the rate is 54 to 80 per minute, which is more than the cutoff of 50, which is a bit of an artificial cutoff, and as long as the growth is maintained, I will follow them up weekly. And if the heart rate goes below 50, I'll start them on salbutamol. And I will try to push this delivery till term as much as I can. Most congenital cardiovascular surgeons will be happy to put in a pacemaker in children above 1.2 to 1.5 kilograms. And that is the bare minimum which I will try to achieve. But then every 100 grams matters, and my preference is to try to push it till term if it is possible. Does the thyroid status of mother have influence on fetal heart rate or rhythm? Yes, it does, but it is usually sinus rhythm. It is not a tachyarrhythmia. So you might have sinus bradycardia or tachycardia due to maternal thyroid problems. But then again, I'm not fetal medicine specialist, and I think fetal medicine specialists are better at this than me. So what is the normal range for AV interval in the fetus? More than 120 milliseconds is definitely abnormal. The normal range is usually in the order of 60 to 80 milliseconds. And once it goes beyond 120 milliseconds, then you think it's first degree AV block. Should transient variations in umbilical Doppler artery be mentioned in your reports? Yes, it should be mentioned in your report, because there is a small risk of future tachyarrhythmias, and mentioning it will, raise the risk ratio for if supposing someone else follows up the next time, they will anticipate this slightly higher risk for tachyarrhythmias. Are VA and AV intervals interrelated? Yes, they are. They are the opposite. So we usually go by VA intervals. What is the treatment for positive antibodies mother to prevent fetal bradycardia in future pregnancies? People have tried IVIG. You need to give it almost weekly from 16 weeks to term. It's a very expensive affair, and the benefits are very much in doubt. So I won't recommend it for anyone. The other option is to start dexamethasone therapy from 16 weeks, or as soon as you see increases in AV interval trends. People have tried hydroxychloroquine and have shown promising results, but then you will have to weigh the risk-benefit ratio. And I generally tend to have a discussion with the family, and if the family are very keen to try the therapy and are willing to accept toxicity, then I go for dexamethasone. Hydroxychloroquine, the data is emerging. I have not personally tried it yet, but I will be willing to try it in a family who are keen for that option, especially because the toxicity profile is more favorable than steroids. Can steroids help in Sjogren's mother? I hope I've answered that. Are VA and AV intervals interrelated? Yes. So the VA interval is the opposite of the AV interval, as I mentioned. Tachycardia-induced cardiomyopathy with PAC or AVRT, how often? Tachycardia-induced cardiomyopathy never happens with PAC. AVRT, yes, it can happen. And the evidence for tachycardia-induced cardiomyopathy in the fetus is hydrops. If you see pericardial effusion, ascites, or skin edema, that is tachycardia-induced cardiomyopathy. And it depends on how high the heart rate is and the duration for which it has persisted. So if the mother presents to you, within a day of onset of tachycardia, you will almost never have evidence of hydrops. Whereas if they present after a week or two, you will almost universally have hydrops. When the pacemaker can be put at the earliest, you can put it on day 1 of life. But the weight matters because you'll have to fit in the pacemaker, and usually stop share. And the rate, usually most cardiologists are comfortable with, cardiac surgeons are comfortable with a weight of around 1.5 kilograms. Why wait for the fetal heart rate to drop below 50? Because signs of high drops are very rare below the rate of 50. All you want to do is maintain a bare minimum heart rate so that there is, the cardiac output is adequate and there is no high drops. And that never happens at a rate of 70 to 80. And as I mentioned, with chronic salbutamol therapy, you develop tachyphylaxis. So the drug becomes inefficacious. So you reserve it for those who really deserve it. The dexamethasone dose, I think the dose they use is 8 milligrams daily, but I personally never used it, so I'm not aware of the dose. I'm really sorry, but I can find it and share it through Mindray. Now, do you guys want to go back to the quiz and discuss the answers? Arumugam, can you bring up the poll, please?
Okay, sir.
I think we've had the answers for most of this in our discussion. So yes, so what are the commonest arrhythmias in the fetal period? Premature atrial contractions, as we discussed. The second question, an antenatal mother presents to you at 28 weeks. The fetal ventricular rate is 60 per minute. Most of you have said you'll choose dexamethasone. Unfortunately, dexamethasone is not going to work when fetal heart block has set in. IVAG has absolutely no role. Induction of labor, not at all, especially with 60 per minute, which is a reasonably adequate heart rate. And salbutamol, I personally prefer not to use it because of the problem with tachyphylaxis and because it's not going to have much of an additional benefit. The third question, a mother presents with decreased fetal movement at 37 weeks of gestation, I'm going to deliver and treat the baby. It's much simpler, much safer, and you're not going to put the mother at any risk at all. So I will deliver the fetus. The fourth question, your drug of choice for fetal tachycardia without high drops. Now, this is a matter of preference. I know of cardiologists who are more happy using flecainide. My personal preference is sotalol because that is the drug I'm most comfortable with and because it has a much favorable side effect profile compared with flecainide. Direct fetal therapy has absolutely no role at all. And digoxin monotherapy, when you have much better efficacious agents with no significant increase in toxicity, I do not think is an appropriate option in this day and age. The last question, a mother presents to you at 30 weeks. There is a family history and you notice 2:8 block. Will you start salbutamol? Not at all, because you can worsen things if it is long QT syndrome. So try to objectively rule out long QT syndrome before you think of starting salbutamol therapy. In fact, if it is long QT syndrome, the treatment you're going to give for the baby is the opposite of salbutamol. You have to give beta blockers, not beta agonists. I hope I've managed to answer all the poll questions satisfactorily. And thank you for all of your interactions. I'm sorry, Vishal, you've asked again, what is the normal range for AV interval in the fetus? I did reply that the normal range is probably around 60 to 80 milliseconds, and more than 120 milliseconds is considered as first degree AV block. So 80, I'm sorry, not 60 to 80, 80 to 100 and more than 120 is considered first degree AV block.
So thanks, sir.
Yeah, thank you.
It was an exhaustive and highly focused clinical session on fetal arrhythmia. A lot of positive responses in Facebook and YouTube as well. Thanks all delegates for your active participation and continuous support to Mindray. With all your support, Mindray will promote clinical education programs throughout India. My sincere request to all the participants, please, there is a link posted in the chat box. Please click the link and share your feedback about this webinar so that we can improve our webinars in future. It will take just less than a minute. Please fill the survey form. Thanks all again. Thanks, doctor. Thanks my Mindray team, my marketing team, application team, sales team, and all our seniors